Surgery during pregnancy presents unique challenges. The presence of two patients, the mother and the fetus, complicates decision-making. Today, we'll discuss common surgical emergencies in pregnancy, their challenges, and best practices for management. Anatomical displacement, altered physiology, and limitations of diagnostic imaging make surgical diagnosis difficult. Surgeons must balance risks carefully, as delays in treatment can lead to severe maternal and fetal complications. Appendicitis affects about 1 in 1,000 pregnancies. Fetal loss rises dramatically in cases of complicated or perforated appendicitis, up to 35% in severe cases. Gallstone disease affects up to 12% of pregnant women, but only 0.3% develop symptoms. Conservative management often fails, leading to recurrent symptoms and complications such as cholecystitis and pancreatitis. Diagnosis is challenging due to anatomical shifts and unreliable scoring systems. The accuracy of ultrasound scanning is low beyond the first trimester. While MRI is highly effective, access is limited in some centres, leading to potential delays. Current guidelines recommend surgical intervention, yet non-operative management remains common, increasing risks. While the American guidelines favour laparoscopy, UK guidelines do not, citing increased miscarriage risk. However, evidence is mixed, and we need higher quality studies to determine the safest approach. Early surgical management is recommended for symptomatic gallstones. Laparoscopic cholecystectomy is the preferred approach in all trimesters, reducing maternal and fetal complications. ERCP remains an option for cholecystectomy as fetal radiation exposure is minimal. However, the procedure should be performed by experienced clinicians to minimize fluoroscopy time. For patients with an IBD-related stoma, complications are common. Stoma prolapse 11%, peristomal hernia 3.5%, and intestinal obstruction 8.5%, often requiring surgical intervention. Proactive management and close monitoring are essential. Surgeons must be prepared to address these complications swiftly to ensure both maternal and fetal well-being. Surgical management of pregnant patients demands a multidisciplinary team, including obstetricians, neonatologists, anaesthetists, and midwives, to optimize maternal and fetal outcomes. Guidelines suggest proactive surgical management, but patient concerns must be addressed. Balancing medical recommendations with patient preferences is key to successful outcomes. Surgery timing is critical. The second trimester is often preferred. Avoiding maternal hypertension and ensuring fetal monitoring are essential. Post-surgery, consider thromboprophylaxis and a gradual return to baseline physiology. Despite advances, evidence is still lacking in many areas. National databases and standardized reporting are needed to improve our understanding. By optimizing surgical care in pregnancy, we safeguard 2 lives at once. Read the full article only on bjsacademy.com.